Good morning, everybody, to my lecture series on headache, commonly found symptoms in the OPDs. Now, when there is nausea, then intranasal sumatriptan or sublingual rizatriptan or zolmitriptan, like intramuscular sumatriptan, may be preferred alternative to oral triptans. As yet, there are no published head-to-head comparison studies of the various triptans. Sometimes patients whose migraines fail to respond to one triptan respond adequately to another. Before the triptans became available, when the non-narcotic analgesics failed to control the migraine pain, then serotonin antagonists such as ergot could be helpful. Nausea was a frequent side effect of ergot. It could be prevented in some patients if metoclopramide was taken approximately half hour before the ergot. If ergot was taken too frequently, the headache might reappear when an attempt was made to withdraw it. Excessive doses cause the peripheral vasoconstriction. Because of its vasoconstrictive properties, ergot was contraindicated when coronary artery disease was suspected and in pregnant women. With triptans and many alternative analgesics available, the role of ergot treatment is diminished. However, intranasal dihydroergotamine (DHE) can be effective and well tolerated in some patients who respond inadequately to triptan treatment. Opiates rarely are indicated in the treatment of migraine. However, when severe migraines are infrequent and other measures noted above have failed, and there are no contraindications such as history of substance abuse, then abortive treatment such as a history of substance abuse, then abortive treatments for the migraines with combination with opiates can be reasonable. For mild to moderate pain, combination of acetaminophen, codeine or oxycodone are reasonable. Alternatively, slow-release oxycodone can be prescribed. For rare, very severe migraines, hydromorphone may be appropriate. Butorphanol, an opiate antagonist, can provide pain relief. However, it is expensive and provides no therapeutic benefit related to opiate analgesics. In addition, in general, if there is a good communication between patient and physician, then emergency room treatment should be required very rarely for treatment of migraines. Often and in the emergency room, physicians with neurologic expertise are not commonly available. Treatment often is delayed. The emergency room environment may exacerbate the patient's anxiety, and this may intensify the head pain. However, in those uncommon instances when a very severe migraine continues despite non-narcotic analgesics, triptans or serotonin antagonists, then more aggressive treatment is requiring parenteral treatment may be needed. In adults without excessive vulnerability to hypotension or heart failure, intravenous hydration with injection of 7.5 mg of chlorpromazine up to a net dose of 30 mg can be effective. During the infusion, blood pressure and ECG must be monitored carefully. An alternative approach is the intravenous administration of 10 mg of metoclopramide followed 10 minutes later by a 1 mg of DHE. From 0.5 to 1 mg of DHE may be infused hourly as needed, as long as the cumulative dose does not exceed 3 mg in one day or 6 mg in a week. DHE should not be used in patients who may have cardiac or cerebral ischemia. Parenteral opioids combined with an antiemetic or steroids are sometimes required if other approaches are contraindicated or insufficient. So I come to the conclusion of today's lecture session. I will come with more information in my next lecture series. Thank you.